Well, hello there, my friends, and welcome to a brand new live episode of From Patients to Superfans, where we dive into how to create amazing customer experiences your patients will rave about. My name is Matteo Trisolini. I help healthcare companies and teams start their customer experience revolution by turning their patients into brand ambassadors. On today's show, we are going to dive into clinicians, burnout, and disengagement. And we're going to try to find our way out of it with the expert help of Dr. Tom Davis, who has all the answers for us and who's going to help us out understanding why delivering amazing customer experiences is going to sustain our businesses financially in the future. And before we bring him on the show, I want to remind everyone who's watching that if you have any questions for Dr. Davis, you can post them in the comments. We'll try to get to them during the show. If you're watching the replay, you can also use the comment section to ask questions to Dr. Davis. So I'm very excited to introduce to all of you, Dr. Tom Davis. Hi, Dr. Davis. How are you?
Fine. How are you?
Great. Thank you so much for joining us tonight. I know your time, especially on a Sunday, is very precious. So thank you so much. Before we dive into the topic, I wanted to ask you to please introduce yourself to the viewers and to let us know what you're passionate about and what you're all about.
I'm a board certified and practicing family physician, and I work in consulting space. My passion is to realign incentives between clinicians and their work life, so that everybody can have a great experience.
Well, that sounds like a lot of work, because I see it from the inside out. This is not the easiest task on earth. But I wanted to ask you, before we dive again into the topics, I wanted to ask you a couple of rapid fire questions. So the way that it works is that I'm going to ask you a question and you just answer whatever comes to your mind at the moment, okay? So okay. First questions, would you rather be invisible or being able to read minds?
Read minds.
You know what? Me too. For so many reasons, although, I mean, if you're invisible, wouldn't you be able to be in the room where everything happens and listen in? Or would it be easier to just read minds?
Sure. But I would rather figure out what other people are thinking, so that I can help them achieve the goals that they're looking for.
Very well done. I see what you did there. I like it. So second fire question is cats or dogs?
Dogs.
Dogs. Same here. Last rapid fire question is, I'll wake up tomorrow morning and I will be in.
Can you repeat it?
Where?
Go ahead and repeat the question.
Oh, okay. Sorry. So the question is, I will wake up tomorrow morning and I will be in
my home.
Oh, all right.
In a good place.
I like it. Me, I'll be on the beach probably every day of my life if I could. All right. So let's dive into the topics here. I noticed that whenever you talk about the subject, you use specifically the word clinicians, and other professionals like to use the word physicians, right? And I might understand why you do this, but I want to hear from you, why clinicians and not just physicians?
Well, because physicians are only one part of the entire care team. And when I say clinicians, I'm not just referring to the nurse practitioners, the physician's assistants. I'm also referring to the registered nurses, the licensed practical nurses, the medical assistants, the front office staff. Everybody has to work together in order to create the engagement that is needed to promote health among our patients.
I agree with that. And I think that one of the most difficult things is to put together a team, and that includes front staff, as you said, mid-level, backhand and doctors and all clinicians involved that work together towards the same goals and that run on the same values. I feel that is a really difficult thing to achieve.
It's all about aligning incentives.
Explain a little bit. What do you mean?
Well, Charlie Munger from Berkshire Hathaway is famous for saying, "Show me the incentive and I'll show you the behavior." And it's the same thing with clinicians. You don't complete our degree of training, no matter what level you are. And you certainly don't enter into the healthcare space without a personal mission of service, some level of curiosity, and then some level of expertise. And the more that you invest in your training, the greater the financial return should be on your efforts, but also the greater the emotional return should be as well. And currently, in our current healthcare system, Matteo, what is rewarded is value. If you go behind the doors when they close in the executive suites, you hear repeatedly the fairly offensive term "moving the meat," and that just simply means generating billable encounters. And I'm a physician first, but when I get behind closed doors, a lot of times the folks there forget that I'm a doctor, and so they start talking like I'm a businessman. But I'm a physician first, and when I hear terms like that, it tells me that there is a fundamental mismatch between the personal mission of the clinicians carrying out the organization's goals and the organization itself. And that's why so many underperform, and they really rely on financialization tools like commercial real estate and selling patient information to generate revenue, instead of trying to generate revenue by meeting the patient's needs.
Right. I see that. Absolutely. In the healthcare system, for the viewers that are watching and maybe they're thinking, well, whoa, what are you guys talking about? You're supposed to be, in good wealth, right? So we get paid by, if you're in private practice, for example, you get paid by procedures, right? Or encounters. So however you want to think of it, and for as much effort that you put into patient care and patient experience, you still get paid the same amount of money. And you still get paid. Whether that patient is happy or not, you're going to get the money. So I do see how the effort that it takes to create an experience for the patient, it's not, is it worth the money that we're making? What are the reasons you think there's disengagement?
Well, you make an excellent point, because compensation is not just financial. Compensation, no matter what you do, is fulfillment of your personal mission. And I mean, it doesn't matter if you're an artist or a rock star or or a business executive, you have a personal mission, and fulfillment is how closely your vocation allows you to do that. The real crime of the fee-for-service payment system is that in its commoditization of patient care, it robs the clinicians at all levels of their ability to fulfill their personal mission of service. Because let's face it, if any one of us, if we were smart enough to make it through medical school, we were smart enough to go into banking or finance and participate in the financialization, which is occurring now. That's the primary source of money. I mean, I personally could have made more money in any of those sectors than in patient care, but that was not my personal mission. And really, the tragedy here is that the clinicians now are essentially forced, for the most part, to participate in a fee-for-service payment system. They really don't have any other realistic choices. There are some cracks in the dam, but for the majority, it's fee-for-service, and they see that system commoditizing the patient and really commoditizing their own labor, and it's very dehumanizing on all levels, all to simply earn a buck. And it's not sustainable. It's not moral, and it's not right. And that's why these new payment systems that are starting to come online a little bit are causing a little crack in the dam, Matteo. And when you see them being run effectively, the effect is transformative.
Tell me a little bit more about this. Give us a little bit more details, because I think that I have a feeling that the viewers might be thinking, okay, what is this exactly that you're talking about, Dr. Davis?
Well, for comparison's sake, to start out with, the fee-for-service payment model that we use is basically the clinician delivers a service to the patient and then bills whoever is responsible for covering the cost of the patient's care. It's an insurance company, the government, whatever, for that service in return for a pre-negotiated payment rate. So that's why it's called fee-for-service. But now, because that payment system is so inefficient, and for a variety of other reasons, there are now really an emphasis or a growth of value-based payment systems. And this is basically it. Value is defined by how much an individual's care should have cost minus how much it actually did cost. And organizations who are paying the cost of a person's care, insurance companies, Medicare, they set a budget in a variety of different ways, and they contract with a clinician in order to manage that patient's care under the budget. And if that clinician is over budget, it comes out of their pocket, and if the patient's care is under budget, the clinician gets to keep it. And really, that totally aligns the incentive between the clinician, the patient, and the payer. And Matteo, the only other way out of the fee-for-service trap is to simply have people pay for their medical care themselves through direct care systems. And those are starting to pop up by the primary care doctors who are leaking out of the system. And those too are very effective in terms of generating payments based on the value that the clinician generates. In that case, Matteo, the value is simply what the patient thinks that the service is worth, and we're paying for it all. And I myself have a direct primary care doctor. It's fantastic.
See, so I want to ask you two things. One is for the direct payment model that you're talking about, right? Do you think that that's more realistic in an urban area such as where I live, New York City, for example, where there is expendable, budgets that people might have? Also, there's a level of expectations that is a little higher. What's your idea about that?
So it is absolutely viable, except for one characteristic, and that is the supply of clinicians that are even competent to offer that care is woefully inadequate. As an employed clinician, I carried a patient panel of over 3,000 patients. That was almost 3 times what the recommended number is, and the recommended number was twice as high as what it should be. So a good single clinician direct primary care practice will usually top off at between 500 to 700 patients. And so if you start having every family practice in general internal medicine and doctor of nurse practitioners and NP and PA just take care of 500 patients, Matteo, there's just not enough workforce. And honestly, that is a reflection of the fact that under fee for service, people get paid for people get paid more for doing something than for thinking. And as a consequence, there are way more doctors who do things than who primarily think about things. Now, the surgeons and whatnot, they got to think before they do. I'm not degrading that. It's just that procedures pay more than diagnoses. And as such, you got more proceduralists and fewer diagnosticians. So then the primary supply of primary care clinicians has been crushed. And as an aside, my daughter is just finishing up her master's degree in counseling psychology. It's a complex program, but she can command as much per hour as I can on the open market as a general practice family physician, about $120 to $130 an hour. So you can, compare the relative value, but Mateo, it took me 11 years to get trained in my specialty. It only took her 6. So no matter what you think about the relative value of that, if you allow that situation to continue, you're going to have a real hard time attracting the right people into primary care medicine.
Right, I hear you. And the other thing that I think that happens is that you get so busy. For example, again, when you're in primary care, you get so busy because you need to have a panel of, if you have 3 doctors, about 30,000 to 4,000 patients to survive in the business, to pay all the bills. I'm going to give you an example. For example, in pediatrics, there's overhead expenses that are really mind-boggling to me. Like the rent, for example, it's like on the list probably number 10, 11, right? So in pediatrics, we have to have cash available to purchase vaccines, which are incredibly expensive, right? And the reimbursement from the insurance companies is really stinking on that. So that is a service that you get paid for, but it's something that you do, but you really don't make much money on. So, and then in the daily routine, you get so busy that thinking about other ways to survive becomes also kind of impossible. Just to even sit down, stop for a second and think, wait a second.
If you go to the top MBA schools, you will learn that busyness is an intentional tactic to keep any professional employees, not just doctors, but any professional employees you have in your organization from becoming aware of the value that they generate. So it doesn't matter if you're employed or you're in private practice, but taking third-party payers. The tactic from all of these folks is to keep the provider on the treadmill, wearing blinders, working 12 hours a day, so they can't get the vision, they can't get the perspective of how futile their journey is. And that has been one of my great personal value propositions. I was on the treadmill for 25 years. I bow to no one in terms of my time running with the blinders on. But I've been fortunate to be able to step away and have perspective so I can share with my peers exactly where the path that they're leading is going to. And it's difficult to hide that now, Mateo. Clinicians are they're disengaged, they're burning out, they're trying to assuage their pain with sex, drugs, addiction to money. They're trying to cover their pain, and they're killing themselves in record numbers. In 2019, medicine became the most dangerous profession of all professions to participate in from a suicide risk standpoint. They just eclipsed dentists in the United States. That is a crime, and that's one of the most concerning things about our healthcare system, because by the fruits you should know the tree. And if there's not a change, you're really going to start running out of people who are willing to make the enormous sacrifice to train to be a clinician. And the first step is to create systems where they're not so busy, so that they can fulfill their own personal mission in an effective and enjoyable way.
So what's your advice for anyone who would like to stop running on the treadmill and look for other options for their future so that they don't get into burnout?
The parallel, Mateo, is being a crack addict. I mean, it's simple as that. For somebody who is deeply addicted to the busyness, to the treadmill, the first step is you just got to stop. And just like if you have a chemical addiction or a sex addiction or a money addiction, whatever it is, the first step is just got to stop. Cutting down just doesn't do it. You got to stop. Put yourself in a position where you can provide yourself a buffer. And then once your vision starts to clear, it is amazing the opportunities that are out there for clinicians who want to work in the system in a different capacity or delivering care in a different way. The options are out there. The regulations have not completely pushed us aside. If you want a specific recommendation, there's a book called Transitions, Making Sense of Life's Changes. That's simply mandatory reading. I read it every year. I get something new out of it every year. So read that book. But really, if you're a busy clinician, just jump off the treadmill. You got to do it. I help people with those transitions all the time. And not one of them has said, boy, I wish I was busy again.
I hear you. And that's what I see everywhere. I mean, you know that I'm on Clubhouse, right? And there's a lot of rooms about, they call it physicians burnout specifically because it's a group of physicians, where they do talk about all of this. You know, why am I even running this much? Why am I doing all of this? You know, what is the purpose? Do I love my Audi convertible? I do, but is that the purpose of what I was trained to do? You know, and I think that when you hear all of these complaints, right? And then you also put them all together in the fact that physicians are not alone. As you said, we need to talk about clinicians. We need to talk about the entire team that takes care of the patient. At the end of the day, on the other side of all of these discussions, there's a patient who needs help and also who needs to be treated when they interact with you or anyone on your team as a human. To me, it's as simple as that, right? I tell my team, why do we do all this? This is a lot of work here. And the reason that we're different from somebody else out there is because we put a lot of work into it. But why do we do it? One, because it's just nice. Two, because we are humans, right? And three, why not? Why not? At least this is how we go about business on our end. So before I let you go, I wanted to ask you, first of all, is there a question that you wish that I had asked you?
Only this, and that is, if you find that you are commoditizing human life as a clinician, and again, it doesn't mean at any level, then that is a sign that something is wrong. And you're not crazy. You're not nuts. You are sensing something that is wrong. And if you start seeing that in your workflow, then it's time to take a step back, no matter what level, and see if there aren't other opportunities to re-engage with clinical care in a way where the patient is treated like a human being. Because once you do that, you will rediscover your passion and your mission for care. And that's something that every patient deserves.
Very well put. I want to ask you, if anyone viewing wants to get in touch with you, where do they find you?
Sure. You can connect with me through LinkedIn or at tomdavisconsulting.com. Again, I'm a physician first, so my mission is service. I work as a business consultant and a personal mentor, and I also have expertise in the telemedicine world that predates COVID. So I have a broad array of offering. But the first and primary mission is always of service to my peers, because I have realized that nobody else is going to help the clinicians. It's simply up to us to help each other, and the time for doing that is now.
I agree with every single word that came out of your mouth today. I want to thank you so much for your time. I want to also invite everyone who's watching the show now, before we close, to join our online community. We have a free group on LinkedIn. Of course, it's called From Patients to Superfans. We also have, if you don't like LinkedIn, you can also join the group on Facebook. It's called the 5-Star Healthcare Customer Experience. And I will see you all next Sunday in the afternoon, around 6 o'clock, around the same time. We have a few topics of discussion. We will talk about reviewing our own patients from the clinician's perspective and what is being said right now online about this. We are going to talk about rethinking your hiring strategy. And I'm going to shock you with a couple of things that I learned from some of my friends at Zappos. And we're going to also talk about setting up your culture in only 3 steps. And I'm going to give you an update on Clubhouse. I want to thank Dr. Davis again for spending time with us tonight. And we will see you all next Sunday.